Now, if you see, if you goes on the next slide about the infection control indicators. Once the surveillance have been done and the documented, these forms will be presented to the infection control department, and again it will be scrutinized by a infection control officer and an infection control committee, where as we discussed, the committee infection control is a multidisciplinary committee work. It is not a single person work done by a microbiologist or an intensivist or a surgeon. So, it has to be done as a teamwork, where the ICN collects the data, presents to the infection control officer, and scrutinize the data as per the national and international guidelines, and the same will be presented in the committee and it will be discussed. Coming to the indicators, infection control indicators, we have overall nosocomial infection rate here, where if you see in the slide we have given July and June. It is an example where we have given. Whenever we are presenting the data, we also present the data of the last but 1 month to just have a comparison. Anyhow, we are going to produce the quarterly or half yearly and annually data separately, but for every month data we also have the month before data with us to see for any significant changes or anything in the data. Suppose if it is a cardiac hospital, we also see for the cath admissions, which are mainly daycare admissions. Here I would like to say here that not only cath, I am telling, all the daycare procedures has to be removed from this, because most of them get admitted in the morning and they get discharged on the same day in the evening. So, this has to be removed whenever you are doing the surveillance. Coming to the NCI rate, it is nothing but again total number of hospital acquired infections by total number of hospital admissions into 100. This will give your NCI rate of the hospital. So, whenever we are saying that how many hospital acquired infections we have total, all the COTI, epilepsy, SSI, whatever it may be, then divided by how many admissions we have in that particular month into 100 will give you NCI rate. Coming to the next slide, if you see here, crude infection rate. Crude infection rate is again in a very important entity, where we see the total number of positive cultures from total number of cultures being sent. If you see the formula again, it is a number of positive cultures by total number of hospital admissions into 100. It gives your positive culture rate, how many of them are getting positive. It helps indirectly in knowing the hospital acquired infections. Coming to the next slide, if you see here the crude infection rate data sheet. We also have a data sheet, as we have a data sheet for the surveillance. In the data sheet with the crude infection, again we will record all the details about the patient cultures been sent, what is the date and when the report has come. If you see in the next slide now, the crude infection rate data sheet, where you have the month, year and the culture positives, a number of culture sends, and how many of them turn out to be positive cultures. Here I would like to tell a very important thing. There is a method to collect the peripheral line cultures or a central line cultures for the blood cultures I am telling. If we do not follow the guidelines, many of the time we end up in having coagulase negative staph, or we end up in having the skin commensals like diphtherites or aerobic spore bearers. The reason behind that is again the skin preparation is not proper before collecting the blood cultures. There is a guidelines where it says very clearly, whenever we are planning to collect blood cultures, adequate time has to be given to the patient, explain the procedure, wear the personal protective equipment, at least the sterile gloves, clean the site with a 70% isopropyl alcohol, wait for 1 minute, again clean that particular area with 2% chlorhexidine or 10% povidone iodine, again wait for 2 minutes, allow the antiseptic to act on the commensals, then you withdraw the blood carefully antiseptically with all the antisepsis. If suppose if you bypass any of the procedures, then we will come up or will end up in having coagulase negative staph or diphtheroid skin commensal reports or no bacterial growth in our blood cultures. So, this is very very important for the crude infection rate. If you want your hospital to have a good positive cultures with the proper reports, then these methods have to be followed. Coming to the next slide now about the denominator data. See, just now as I discussed, it is nothing but all the device days which have been managed for the patient in the hospital will be collected in the denominator data, irrespective whether it is a ventilators or it is a catheters or it is a central line days. So, the denominator data I will be showing in my subsequent slides. It gives about the device days on the hospital. If you see the next slide now, the device days checklist, everything should be documented and it has to be reproduced at the time of your analysis. Suppose if you do not document the thing and if you discuss verbally, then when you make a report and analysis done, then there are many chances that you may end up with a wrong information. So, if you see in this, this is again the data sheet where the total number of patients on the Foley's catheters, number of patients on centered lines, number of patients on ventilators, and all these details will be given in this.